home of medicine podcast with me, Dr. Amy Burbridge. I am speaking today. I'm in Birmingham in the United Kingdom, and I am at the Take Acute Internal Medicine Conference, and it's been an absolutely fantastic day. Today, for this podcast, I am joined by...
Hi, I'm Ben Lovell. I'm a consultant in acute medicine working in central London, and I do a lot of medical education work as well.
And I have a very, very special guest.
Oh, this is where I talk.
This is where you talk.
My name is Zack Ferguson. I'm an ST5 in acute medicine, also with a special interest in medical education, and I work here in West London.
Fantastic. So I am really excited about this podcast today. So I'm going to share a case with both of you. And what I really want to get out of today's podcast is to find out how, as a trainee, Zack, you would approach the case.
Mm-hmm.
And Ben, as a aged consultant, you would approach the case.
I'm leaving.
And see if there's any difference in how we approach cases. Okay, so this was a Friday evening. I always like to set the scene. Mm-hmm. So it's a Friday evening. It was 6:30 in the SDEX, in the same day emergency care unit. And a 19-year-old female turned up. And she was referred from the emergency department with nausea and vomiting and some abdominal pain. She came in with her mum and she looked incredibly well. And it was one of those cases that you pick up and you look at the notes and you'll be like, I finish in 30 minutes. I'll be able to see. We don't even need to do this actually. And I'll send her home. So I went over to see her thinking I've got 30 minutes, and I sat down and I opened the consultation, started to take a history, and she looked fit and well, 19-year-old, and she said that for about 2 weeks she'd been feeling very tired, been feeling nauseous, had occasional episodes of vomit. She'd also had a few episodes of diarrhea and hadn't been hungry, so her appetite has completely reduced. Aside from that, she had no symptoms at all. But her mum was really, really worried about her. And she said, she's just not right. And I cannot put my finger on it, but she's just not right. She'd been to the general practitioner a few days previously. And the GP had said, actually, she's been working lots of long hours, probably nothing to worry about. Just have rest, get some good sleep, get some good food in, and hopefully you'll feel much better. So I took the history and I asked a few more questions. And while I was taking the history, I noticed that she looked a little bit yellow. So I said to her mum, do you think she's changed colour? And she said, no, she's always that colour. She uses huge amounts of fake tanning agent. So I said, okay, but I actually thought her eyes looked a little bit yellow. She said, no, it's always been like this. Okay, fine. Let's not go too much more in depth about that then. So, Zack, as a trainee, what would you do with very non-specific symptoms like I had in this case?
So, having gathered all that initial information, I suppose the first decision we're going to make is how extensively we need to investigate this. Difficult not to suspect there's something a bit more complex going on, merely by the fact that we're discussing on the podcast.
Absolutely, okay.
But certainly the suspicion that she may be jaundiced and yellow of eyes has probably pushed me into the yes, I am going to do bloods on her sort of category.
Yeah.
And if I'm finishing in half an hour, that's probably also pushed me into this is something we need to look into in a bit more detail.
Yeah.
My first approach has to be, is this something that we need to deal with this evening, or is this someone who can come back tomorrow for a more extensive review? What was telling for me in the history is the fact that she's essentially reattended, having already spoken to a GP. Which means one of two things. Either we're missing something really quite significant and need to investigate further, or we're going to need to do some therapeutic investigation because this is someone who's going to continue to present because they're concerned, and unless we have at least done a little bit of a workup, their minds are going to be put at rest. So those are the initial thoughts going through my mind, with the obvious caveat that the first thing I'd like to do in a 19-year-old female who's nauseous with some abdominal pains and pregnancy test.
Absolutely. And I think I say this in every single episode. Every woman is pregnant and talking about this. And that's a really important thing, actually, that is that importance of the pregnancy test. That cannot be overemphasised. If you're right, she's nauseous, she's vomited, is she pregnant? No. Okay, that's fine. She wasn't pregnant.
Had she already had that test? But I was just thinking from the pathway that she's come in.
Absolutely. She hadn't had a pregnancy test done. And she hadn't had a urine dip. In fact, no investigations had been done at all.
So that's obviously an initial, and I suppose in terms of I mean, my approach to SDEC is always, well, not always, but a lot of the time, is this something that we need to extensively look into now? Because there are often patients who are like, you need a bit more of a workup, and come and see me tomorrow if I have the luxury of doing so. In terms of urgent things, I'm going to rule out, again, some non-specific abdominal pain in the 19-year-olds who have been well for some time. I'd also be concerned about first presentation of diabetes, so that's probably someone I can get, at the very least, a blood glucose off one. And then once I've ruled out sort of could this be an emergency, then it's someone certainly with the, with the possibility of jaundice who definitely needs a more extensive set of bloods. If not that evening, then at the latest the next morning. Yeah,
absolutely. Completely agree. And to be honest, I hadn't thought about the diabetes. That's really good actually to check that BM, because that was something that slipped my mind is young person, non-specific abdominal pain, could this be first presentation of EKA? That's a really good learning point. Absolutely. Ben, anything else you'd like to add?
I completely agree with the clinical direction of travel here. What I thought about when you first said you in the last 30 minutes of your shift. If anyone will take advice of someone who's been around the block a few times, don't pick up new patients in the last 30 minutes of your shift.
But I always do.
Don't do it. You cannot do the patient justice because you are not treating the patient, you're treating the patient against the clock. And every decision that you make is done with one eye on the clock on the wall or one eye on your watch. And I think even subconsciously, there's the danger of choosing options in care which get you out the door a bit sooner. There's no such thing as a quick patient. There kind of shouldn't really be us forcing people to make quick patients. So that's what I would say.
No, that's a really good point.
And how many times have you picked up the easy, quick patient and some absolute complex chaos evolves over the next hour? And then you've got to think about how long am I going to hang around for to wait for this result or wait for this to happen? And who am I going to hand over to? So I do think the last half an hour of your shift is the time where you start winding down. You tie up the loose ends of the shift. You make sure everything's done safely. And you think about the handover you're going to do in the next 30 minutes. If you're working in an environment where every second counts and you've got to get that patient clear, I completely understand. But I advise try not to do it unless you can, because the patient you see in the last 30 minutes is not getting the same doctor as the patient you saw in the first 30 minutes of your shift due to lots of different complex human factors. Medically speaking, it sounds like either she's spray tanning her eyeballs or you think she's got some jaundice. So I think she definitely has got some bloods going. I actually work in an SDEC where I don't make decisions about who gets bloods. They get bled, I think, as they sort of check into the car park. And then they arrive with their blood results, all in the name of efficiency, but maybe we sacrifice accuracy. But I think she definitely needs her liver function tests checking. And also, did you say abdominal pain? No,
just very non-specific abdominal pain, some nausea and vomiting.
Yeah. I mean,
it
could be an IBD first presentation. It could be a biliary first presentation, the grumbling sort of stones or something like that. So I know we don't have any. Did you say you examined? Have we examined her at this point?
Not yet.
Yeah. So we need to examine her, but already I would be saying let's get some bloods to the labs because that's going to inform my clinical decision here.
Absolutely. And also, what was really important in this case was the history from the mom, because when I asked the patient questions, she was like, "Oh no, I'm fine," and the mom was like, "Actually, no, she's not." And it was really interesting to get that other take. And I often find that with more younger patients, it's really good to get a collateral history. Maybe they're embarrassed to give you the history, or they just can't give you the history. They're not entitled, they can't answer the question. That was really important. So I did some more questions. I thought she looked jaundiced. So I sort of went down the route of, has she got any clinical history? No, she hadn't. She didn't take any medications at all. She wasn't allergic to anything. She didn't smoke. She didn't drink any alcohol at all. She was sexually active, and she had a regular partner who she always used condoms with. So I was thinking, okay, if she's jaundiced, is this a hepatitis picture that I need to think about? And I was a little bit uncomfortable asking these questions when her mum was there. But I felt it was appropriate in that case, and she was absolutely fine and very open and honest with the questions, with the answers of the questions. And no significant family history of note. She didn't really have any urinary symptoms. She was just tired, as I say, reduced oral intake, cardiac, respiratory, all nothing, not specific symptoms really. So I examined her, and when I looked at her, she looked tired. She did have jaundice in the eyes. She was yellow. And I felt her abdomen, and I could feel a palpable, tender liver and an enlarged spleen. Now, I knew I can never feel it with spleen, so I knew that if I felt something there, this spleen must be pretty enlarged. And I now started to panic a little bit, thinking, okay, actually, she's really sick. She's got a very big liver. She's got a big spleen. What am I going to do now? Did you find anything else of note? Any other signs of acute liver disease? And I didn't find any signs of chronic liver disease on examination. So I then did some investigations, and the key investigations of note, and the only abnormal ones, were the liver function tests. So the bilirubin was elevated at 45. So that's nearly 3 times the elevation what it should be. When I looked at her alkaline phosphatase, that was 3 times the upper limit of normal, and her ALT and her AST were also 5 to 6 times the upper limit of normal. So she had an hepatic picture and a post-hepatic picture of jaundice. So I was now thinking, what am I going to do? Am I going to admit? Do I need to admit this lady? Can I send her home? What further investigations do I need to do? Who do I need to talk about? Do you know what? Because it was the end of a very long day, I panicked, and I couldn't make that decision. So I started to ask other people for a second opinion, and there was nobody really around to ask the second opinion of. And you know, when you get to that stage in the day, you get decision fatigue, and you actually don't know what to do.
I do know that very well. Yes.
Yeah.
Yes, that is something very familiar to me.
And it was a real, I couldn't think. I didn't know what to do, and I started to think it's the best thing to do just to keep going. Knowing that it was a weekend, knowing that nothing would be done over the weekend. And she still looked well. And it must have taken me about 20 minutes to make a decision about whether I should admit or discharge. Spoke to the patient, what did she feel was best. Any thoughts, Zack?
Oh, that is a really tricky one, because I think the answer would be really obvious if it was 9 o'clock in the morning. It would be, I'm not going to admit her, I'm going to keep it here in MLH care, I'm going to get some extra opinions, we're going to get some imaging. It would be, and then if 6 hours later you've got more information and she's remained well for those 6 hours, you know, she's not coagulopathic, you know, there's no evidence that she's been fulminant hepatic failure, then the decision's a lot easier. But I as potentially fascinating as the case is, I think that difficult decision is made so much more challenging by the time and I suppose where you're working as well. Because it depends on what sort of coverage you're going to have over the weekend, but that's when you're at where's the best place for her to have further investigations. It sounds like she's got a mum who's very vigilant and engaged, which, you know, may sort of tilt you further to, you know, to sending her home and bringing her back the next day to see someone else. I think at that time of day, without any, you know, real information or definite answers, from a training perspective, I don't think I'd send that person home unless they've been seen by a consultant, which feels very much like a, you know, deferring the decision up the chain. But I think, having been given the picture of sort of your state of mind, if I were in that situation, I wouldn't feel confident taking on clinical risk, knowing my own state of mind and having not had the time to work up and see what her direction of travel was.
Yeah, absolutely. And my thought processes were very similar. And what I did, because I couldn't make a decision, is I went back to basics and I sat down with the doctor who was with me that day, and we wrote out on a piece of paper the causes of jaundice, because I couldn't function properly. And I said, okay, let's go back to basics. Let's think about the pre-hepatic causes of jaundice that could be causing this patient's jaundice. So let's go back to basics and think about those. So pre-hepatic causes of jaundice.
Hemolysis.
Hemolysis. Okay. Was she hemolyzed?
No, no.
Yeah.
No.
So her blood count was small.
Yeah.
She wasn't anemic at all. We hadn't got a blood film at that stage to find out whether she had any histiocytes that was symptom that would show that she's hemolyzing. Platelet count was normal. White cell count was normal. Hemoglobin was entirely normal. So there was nothing to me to suggest that she was hemolyzing. Anything else pre-hepatic?
Well, benign hyperbilirubinemia is like Gilbert's, but why was she ill? You know,
Exactly.
you would never make that diagnosis acutely.
Deranged function.
So I thought, I stopped this down, I was like, actually, I don't think it's anything like this. So now, hepatic causes of jaundice.
Well, okay, infected.
Okay.
I've seen 19-year-olds with acute hepatosplenomegaly and illnesses, and they've had EBV. So sort of a glandular fever screen would be something I've on my shopping list.
Okay, so how do you check for glandular fever?
Well, I'd just check the glands. So look for any lymphadenopathy anywhere else. Check the throat.
Yeah.
Ask if you had symptoms in keeping with an acute bout of glandular fever, and then you would send the EBV serology, which takes time, but maybe you should it back in a couple of days or so.
Mm-hmm.
But even if I thought it was EBV, acute Epstein-Barr, and she looked ill, I still could admit the pain. I've seen people with EBV who can't swallow, because they're in so much pain. And if the hepatitis was severe, I still would admit for that reason. So infection, and of course, other infection would be acute hepatitis B, any other acute hepatitis really. CMV I've seen do it before as well.
Mm-hmm. Just because I've had a case of glandular fever recently with a false negative monospot. But everyone had taken glandular fever off the table, so the monospot's negative. They came back the next week still with symptoms. We ran the EBV serology and it came back. So I think I don't know how common that is. I haven't had a chance to look it up, but sort of work considering that that's a diagnosis that yes, absolutely get it a couple of days to get that serology back. Yeah. It's certainly based on that experience. I wouldn't take EBV off the table even with a negative monospot.
And also, tests aren't always right. They aren't always, just because we do a test, it doesn't mean that. Sometimes tests make mistakes too, and the machine might not be working properly. You get a lot of false negatives, false positives. So it's really important to bear that in mind. So yeah, you've got your infective causes. You mentioned EBV, CMV, Hep A, B, C, D, E. Absolutely. So paracetamol. Had she been taking paracetamol? Had she took a paracetamol overdose that we didn't know about? Did she drink high levels of alcohol that we weren't aware of that needed very sensitive questioning around potentially? Had she got one of the more unusual autoimmune conditions? Had she all of a sudden developed primary biliary cirrhosis, unlikely in her age, but these things I started to write these down because this was the only way that I could make a clinical decision, was to write everything down. For this being primary sclerosing cholangitis, she got Wilson's disease. And it was about, okay, very unlikely, but I need to write them down, then cross them out to make sure that I've thought about it, reason why it wasn't this, and then reason why it could be that. So we looked at any other hepatic causes of jaundice that I need to do on my acute jaundice screen.
I think that you just want to make sure there's no hematological malignancy as well.
Yes, that's a really good point.
So I would be asking about B symptoms, weight loss. You said she's got no appetite.
No.
In terms of immediate tests, there's not really much to do, but I would keep in mind, do I need to image and look for any signs of a lymphoproliferative disease if I'm not yielding any good results from my initial screens? Yeah,
and that's certainly a cause of hepatomegaly and splenomegaly, isn't it? So yeah, absolutely.
A lot of tests that won't be back for several days.
Isn't it?
Yeah.
I know. And that again has to go into your decision-making process, doesn't it? What about post-hepatic causes?
Well, biliary tract obstruction, stones, pancreatic malignancy, gallbladder malignancy. Again, don't tend to be diseases that I have ever seen in some age group.
It was a real challenge, this case, because I didn't know whether to admit or discharge. And that was the key question.
Yeah, I've got to say for that, I remember as a trainee, Zack, I was always worried that if I was stuck on the fence well and I decided to admit, I thought, am I going to get in trouble? Or if the consultant saying, why not did Ben admit this patient? Look how well they look now. And that always stayed with me, even though I was a consultant, because the way acute medicine is often set up, it might be a different consultant tomorrow post taking someone or reviewing someone on the ward that I admitted today. So if I'm admitting someone and I'm really on the fence about whether they come on or not, and I decide to admit them, I always put my reasons down.
Yes.
So I say plan, admit, rationale, bullet point. 1 has an acute hepatitic picture, which may well worsen and become fulminant in a short period of time. So just so everyone knows what my thinking was at the time, leaving a mind line that people can follow the next day, because I might not be around to justify. And I don't worry that people are going to come and, tell me off, but I want them to know that I did what I did for a reason.
Yeah.
And sometimes, and we have mentioned this on a previous podcast, a patient doesn't, you said, oh, they're not going to do anything for them. It's just the weekend. They're not going to get treatment. But sometimes they just need a bit of good old-fashioned vitamin T, which is time. So it's like, they're not going to get anything at the weekend, but I want to see what you look like at this time tomorrow.
Yeah,
and then I'll have a trajectory, and then I can maybe make a more informed decision about where we go from here.
Yes,
but without
time is the best thing we can do, isn't it, for a patient?
And I remember a few years ago, there was this intervention, but, you know, we're so desperate for beds. They're saying, don't admit a patient unless it's for hospital treatment. And I'm like, I mostly agree with you, but there are a very small portion where sometimes I'm admitting them because I want to get a trajectory. I want to get a direction of travel for the patient. And it may turn out that they're absolutely fine and admission could be avoided. And I appreciate they're getting no IVs tonight. They're getting no oxygen tonight. They're getting no hospital-specific treatment tonight. But I need to see what they're going to be like in 12 hours' time, and then I'll know. And I think that's safe. And I think we have to remember those patients exist. So we don't just fall into the trap of saying we only admit people to hospital if they're getting hospital-specific treatments within the next 24 hours or so. That's mostly true, but not 100%.
I think that particular risk profile, those is exactly why experience seeing clinical decision makers is so useful, because that gestalt of spotting that patient who, a lot of the time they may not become more unwell and you might be being overly cautious. They fit that profile of someone who has the potential to go awry if they are left on their own. I guess my question for both of you would be is this the sort of patient who, if the setup allowed it, you'd be bringing back, the next day, if you knew they'd be seeing someone, either yourself or someone sort of similarly minded. Maybe not if you're trying to do all of this late on Friday, but saying you could see this patient earlier in the day and knew, I'm on tomorrow. Is this the sort of patient who you would be willing to send home? And if not, why not?
So
if you take the sort of Friday late.
I mean, if I'd seen earlier on in the day, I would have hopefully got an ultrasound scan of the abdomen, of the liver, to look at the liver. I would have hopefully had a conversation with maybe a gastroenterologist, or I got a second opinion from another acute physician about, what can I do? I may not have needed to have done that though, if I was 9 o'clock in the morning, tip-top shape, and able to make those clinical decisions. What I did in this case was, after going through the courses, which we've just done, sending off this liver screen, far too many tests. I would never have done this, but I was panicking and I didn't know what to do. So I think I even sent off a urinary ceruloplasmin. I know, what's wrong with me? This is what happens when you're tired and you're trying to. I was overthinking because I was worried about underthinking, so I requested the ultrasound scan of the abdomen. And I also thought, is a synthetic function of the liver okay? Clotting function was normal, so I wasn't worried that she was about to go into formal hepatic failure. So I actually sent her home. Whether that was the right thing to do or the wrong thing, I don't know. But I sent her home. I wasn't working that weekend. I was back in on Monday. And when I came in on Monday, she was sat there in the waiting room with them all. Thank goodness. She's been fine over the weekend, and actually her mum was really keen to take her home. Said she would keep a really close eye on her, and I safety netted and said, if there's any problems at all, please come back in ASAP over the weekend, and we'll see what we can do. I also said to her, this is going to sound bonkers, but we try and get rid of the fake tan because it was so distracting because of the colour. I wanted to see what her skin was like as well. Was she actually gorgeous? And when she came back on Monday, I'd arranged an ultrasound scan, which unfortunately didn't get done that day. So I then was in the situation where I was still waiting for investigations to come back. I still haven't had the ultrasound scan. What am I going to do now? Right, but at this point, it was a Monday. It was a morning, so I had much more ability to think clearly. I repeated the liver function test, and then slightly worse. Still hadn't got any other tests back, and again waiting for the ultrasound scan, which they then scheduled for the following Thursday. So at this point, I was like, I'm going to have to admit it. I don't know what to do. And I spoke to a very friendly gastroenterologist who said, I see these all the time. Send her home, she'll be fine. And I was like, what? Okay. And I did send her home. She had an ultrasound scan. The ultrasound scan of the liver was normal, enlarged spleen. And by the point I saw her again, it was about 4 or 5 days later, we started to get bloods back. And her EBV serology was positive.
Which is good news.
Which is good.
Self-resolving illness.
Which is good.
It'll make her feel like hell for a few days, but
Exactly.
it cures itself.
However, that's not the end of the tale.
Oh.
So she had, she was EBV positive, and on repeat liver function tests, they were improving. Great. This is what I wanted to see, and it was fantastic. Her ultrasound scan, however, although the liver was normal, it did show multiple small gallstones. So, did we have two pathologies here? Did we have a patient with EBV hepatitis and also have gallstones? Did she have cholecystitis?
What's your favourite dictum?
Hickham's dictum.
Which is?
Patients can have as many diseases as they damn well pleases.
I would go for incidental pickup of gallstones in a patient with acute EBV would be my diagnosis du jour if I was writing that discharge letter.
Yeah, and I mean, she is awaiting an NRC to have a look further at the gallbladder and the liver to see whether she does actually have gallstones that could have caused these symptoms. Because actually, the nausea, vomiting, the pain could have been gallstones. Was the EBV an incidental finding? I don't know.
She, do you find you get tests done quicker if they're an inpatient? Because that's another factor, isn't it?
Ooh.
Because I often come to a situation where they can't have an MRI until a week on Thursday, but if they're an inpatient, we could probably do it tomorrow. And then you know, that factors in your decision about whether you want to discharge or admit them, depending on how quickly one test's getting done. Did that get a sooner ultrasound for you? Was that factored in, or was that not?
100%.
Yeah.
Because I do find that sometimes if I admit a patient, particularly MRIs, they will get them.
Yeah. I remember very clearly, and I teach a lot of medical registrars now. When I say to SHOs who are about to be registrars, I say, what are you worried about most about being a med reg? And so often one of the answers is whether people can go home or be discharged. And I know that Zack does a lot of teaching sessions with med regs to be as well. And is something you address in your talks as well? The discharge conundrum?
Yeah, I think it's a tricky one. And a lot of it is, I don't think, it's been a long time since anyone's given me a hard time for admitting someone.
Yes.
Certainly, I feel like maybe this is just the point of training that I'm at. I feel like I'm more likely to get in trouble if I discharge the wrong person and admit the wrong person. I think part of it is we don't acknowledge enough, both in the way that we manage systems, but in the way that we train people, the fact that, of course, people who present with some degree of complexity sort of in the evening are more likely to be admitted than people who present at 9 in the morning. And I don't think there's really a way of altering that. That's almost just following our own circadian rhythm. But I think it is always the conundrum that you come back to. And I think it's possibly because if you send someone home and if you do what you did, which is safety net them perfectly and explain exactly when to come up and really relieve the patient of any guilt in coming back, saying it's not a problem if you come back, we want you to come back and change it. And then they come back. Often that is the thing that you sort of get pulled up on, like you sent this patient home and they came back, even though that's what you wanted them to do, something changed. So I think it is a really difficult decision for a trainee to make. And I think most people would err on the side of, if it's an option, admitting rather than taking that risk. And
there's responsibility from us as consultants. Not why would you give someone a hard time for making a judgment call like that? Why do you admit this patient? I think what's something we're guilty of as well is that we're seeing the patient with way more data than the person reviewing the front door did. Yes. And if we're using your example, you can imagine someone saying, why on earth did you admit someone with EBV? It's like, well, we didn't know that's what it was. And I think in acute medicine, we're very guilty of doing this to our ED colleagues as well. We're saying, why have you referred me a case with a patient of X? And said, we didn't have a diagnosis of X when they came in. We just had a sick patient. And now we've done a lot of diagnostics and you have this data done. And now you get to make an informed decision. Because the bottom line is, don't give anyone a hard time who's doing their best in the moment with the information available.
I don't think it's really difficult to put into words how much scarier can something can seem when it's dark and you're on your own versus when you're doing the morning walk around with 10 people.
And you're hungry and you're tired. And you're right, there's nobody else in the hospital. So when you are on call or in the evening, a lot of the consultants have gone home. So you've got nobody to touch base with. And that's really scary. And even, I've been a consultant now for 5 years. I still struggle with these decisions, which is why I'm talking about it. And actually, on reflection, I probably over-investigated her. why was I checking over Wilson's disease? I was checking over Wilson's disease because I was tired and I couldn't think what else it could be. It was just an inability to make a proper clinically informed decision. So I think I did the best I could do with the brain capacity I had at the time.
What more can you ask from a doctor than that?
I know, but you still feel there's always that feeling, isn't there, as a consultant, that you need to know what to do in every situation. And it's very hard to admit that you don't know what to do.
I think if you go back to the patient as well, I think if you said to a patient, would you prefer your doctor to over or under investigation? They'd say over investigate, please.
Yeah,
even though we know the theoretical harms of over investigation, and I absolutely am not advocating for throwing everything at the wall every time you see a patient. But I think if we just go back to the patient and say, what is the safest thing to do with this patient? My feeling right at this second in time, the safest thing to do is to bring this patient and do this test. And maybe it's not needed. And maybe someone else will say that was silly. But I think it's safe, the safest thing.
Absolutely.
And if we keep that as number one, then I don't believe anyone can give you a hard time for it with the power of the retrospective glasses on and say, well, I wouldn't have done it in your position. And I don't think we should be doing that. One thing I really love about acute medicine is that it is very collegiate. And I think there are a lot of people around who can bounce ideas off. And even if people say, what did you do that test for? I wouldn't have done that. It's not done with malice in my experience so much, although I know people like that are out there. But I'm lucky enough not to have encountered too many people like that in my career.
Absolutely. Okay, so, we've talked about some really interesting points in this case. Yes, we had a young female who presented with abdominal pain. She was jaundiced. Key learning point, did a pregnancy test. If you're not sure what to do, go way back to basics and think about all of those causes of jaundice. Think about how you're going to investigate and how you're going to manage. We talked about safety netting, but we also, I guess, even as consultants, we still don't know what to do most of the time. And it's, when we don't know what to do, what do we do? Who do we reach out to? Who do we ask for help?
And what is the safest decision?
If
you don't know, what is most likely to guarantee patient safety while you are figuring it out?
Absolutely. And I'm thinking about, I should have kept her in.
Well, she's fine. She's fine.
But that's one of those things, isn't it? And we've had patients be sort of called up just to check in. And it's such a relief. You're like, oh no, actually, you're okay.
You're okay.
I made the right decision.
Absolutely.
But a degree of vigilance is necessary for safe practice.
Yeah, absolutely. So, Zack, from this case, short and sweet, I know we haven't been talking for long, but can you give me one clinical pearl or one pearl of wisdom you want to leave with it?
Clinical,
whatever you want.
I was going to say, it is a really powerful experience for a trainee to hear uncertainty from consultants, because role modelling that sort of reflectiveness and a willingness to be wrong or to imagine that you might be wrong is really useful, because that's that rather than a sort of Superman
or Superwoman
sorry it's just so much more useful to hear this sort of conversation than a no, I'm always right.
Oh god, yeah, absolutely. I think the power of reflection, and that's why I really enjoyed doing the podcast. Actually, you talk about a case and you reflect and you're like, oh okay, this is what I would do differently. And as consultants, we have responsibility to talk about uncertainty.
Agreed.
Ben, any last closing marks?
Try not to pick up a new patient in the last 20, 30 minutes of your shift. You're not doing them any favours. You're not doing yourself any favours.
No, thank you so much. Thank you so much for everybody for listening to today's podcast. And thank you to Zack and Ben for joining me. It's been absolutely brilliant. And we'll be back for more. Thanks for listening. Bye.
You've been listening to the Home of Medicine podcast, a podcast brought to you by the EFIM Academy in association with the European Federation of Internal Medicine, a leading organisation in internal medicine. Thanks for listening.